wanted to say welcome. We're very excited to have Dr. Logan tonight talking to us. She's actually done this presentation before, and it was such a hit that I told her we might have to ask her back several times. I'm not sure. So anyway, I'll let her talk and go ahead.
Okay, thank you, Lori.
Uh-huh.
So some of you know me. I'm Dr. Jennifer Logan. I'm a family medicine doctor at UCLA's clinic, literally just attached to this building. And there, as a family medicine doctor, I see everything from little newborn babies up to 100-something-year-olds, and treat chronic diseases and women's health and kind of acute illnesses and everything in between. So the reason I gave this talk on dementia is because it comes up very often in primary care that if it's a concern, it may be managed by your primary care doctor with or in conjunction, alone or in conjunction with the neurologist. So I thought it'd be a good thing to hear, at least from a primary care perspective. And I think that's it. If you have any questions, you feel free to just ask as we go, or we'll talk at the end. If you can't hear me, just tell me and I'll speak up, okay? So we'll just get started here. All right, so an outline of our basic talk today, and if I'm in anyone's way, please tell me. An outline of our basic talk will be to go through a basic overview of dementia and then talk a little bit about the causes, how to diagnose it, the treatments that are currently available, some information about safety concerns that can relate to dementia, and then a brief summary, all right? So let's start with, admittedly, what is a dry definition. Because this is a hard condition to put into words. The brain itself is just so vastly complicated, and never mind describing a problem with it. So there's something called the DSM, which is the Diagnostic and Statistical Manual of Psychiatry, and that is the sort of text that we use to define any psychiatric or neurologic condition, and dementia is one. So bear with me on this definition. This is not just all we use, but we call dementia essentially a measurable abnormality in at least one area of thinking. It used to be a requirement that one of these was memory, but that's something that has actually been changed just with the most recent update of this psychiatric kind of neurologic definition. There's less focus purely on memory because we know that dementia can encompass many other parts of thinking. So it can be language, attention, something called perceptual motor skills, which is sort of an interaction between vision and sensation and movement. And then social functioning, and then what's called executive functioning, which is a larger term that tells us a lot about overall functioning in life and being able to go through your daily activities. In addition to having at least a measurable abnormality in one of these areas, and we'll talk about how we measure that, it needs to be significantly impairing a person's life. This is not just the forgetfulness that we all have, the misplacing the keys that can happen to everyone. It has to be interfering with your life in a significant way, and that's really where the line is drawn for almost all psychiatric conditions, whether it's or neurologic conditions, things like depression, anxiety, all of those symptoms can happen at one time or another, but if they're not significantly interfering with life, we don't treat it as seriously as a condition, if that makes sense. And like I said, less emphasis on memory more recently. So people often get confused about what dementia really means. Is it Alzheimer's? Is it the same thing? Is it different? Dementia is what's called an umbrella term, meaning it is something that covers symptoms of more than 100 different conditions that impair thinking or memory or behavior. Okay, so it is not one disease. It is not Alzheimer's specifically. It is not just memory problems. It's not depression. It is many conditions that cause problems in thinking. The most common subtypes, okay, so these are types of dementia, subtypes of the larger term. The most common is Alzheimer's dementia. So you'll hear dementia of the Alzheimer's type, Okay, that's what how that categorizes within dementia. That's the most common. That's about 50 to 70% of cases, and that's due to abnormal deposits in the brain. That's what differentiates Alzheimer's from other types of dementia. In this lecture, we're going to focus mostly on, primarily on Alzheimer's type dementia, it being the most common. The second most common is what's called vascular dementia. This is something that you may have heard. It means things like strokes or decreased oxygen to a part of the brain that causes symptoms that can be measurable problems in thinking. It often coexists with Alzheimer's type dementia. To make it even more confusing, these things often happen together. You may have heard people sometimes say things like, oh, my mother had hardening of the arteries, and that's sort of vascular dementia. Less common types are Lewy body dementia, which is a type of dementia that can cause very vivid visual hallucinations. And then Parkinson's disease is a problem with a different type of cell in the brain. And then frontotemporal dementia is another less common type of dementia. They all have different subtle causes in the brain tissue that leads to symptoms and different types of symptoms. So that's the breakdown of what is dementia and the different types. To give you a perspective of where we are in the world with dementia, it's an interesting thing to think about that worldwide, over half of the people in all of humankind who have ever lived to age 65 are alive today, right, in 2015. So that means that for most of mankind, people did not live so long as we do now. So almost all people half of the people who ever lived to over 65 are alive right now. So that should give you some perspective about relatively how new aging conditions are, that they are not something we have had the benefit of learning about for millennia. It's been very recent. Dementia, whatever the subtype, affects 36 million people worldwide, and it's very much age associated. You'll see this percent of people affected start at 3% between about 65 and 75 and go up proportionally to about half of those over 85. And there's different reasons for that, which we'll go into. A little bit of the history of dementia, because I always think it's helpful to know where we've come from. For most of human history, it was used as a term describing, applied to anyone who had any problem with thinking, whether it's because they had a bad infection, whether it's because they were depressed or schizophrenic or had brain damage from an accident. Dementia just applied to all of it. And again, remember, most people didn't live as long, and so this is more younger people. After industrial times, it was more just viewed as an inevitable part of aging. It was thought that, oh, since it's so associated with older age and we've not seen so many people who live longer, that everyone must get it. The pictures are Aristotle and Plato. They actually, for a long time, just thought memory was from the heart. They thought the heart was the organ that controlled memory, and sort of dismissed any mental activities that could help prevent dementia. And then there's Roger Bacon was a friar in the 13th century. He's that third picture. And he was the first to suggest that memory actually originated from the brain, but he also viewed it as punishment for original sin. And you'll notice that was a theme throughout a lot of history, that any mental condition, whether dementia, depression, anxiety, bipolar, was often thought of as punishment that needed to be treated with moral therapy. So that's where we were for a long time, until more recently. To give you some background on the history of Alzheimer's dementia, it was first described by a German psychiatrist named Dr. Alzheimer in just 1908. So if you think of all the time that humankind has been around, it was just about 100 years ago that this was even mentioned. So we're really in the infancy of Alzheimer's. His first patient was a woman, who's the picture on the right there, named Auguste D. And she lived a normal life until she was about in her 40s, when she became increasingly agitated and had memory problems, would run screaming through her house, dragging bed sheets around. Her husband could not take care of her and work, so he had her institutionalized at the hospital that Dr. Alzheimer worked at. She eventually passed away in her 50s, and after her death, he, being an academic doctor, looked at small slides of her brain tissue under a microscope and noted these abnormal deposits around the neurons, which are sort of the basic cell components of the brain. He didn't pick up on the significance of that. This was kind of something that was known to be seen in older people who died. He thought, well, it's a little unusual that she's young. There was a lot of pressure for him to publish his paper, so he published it as just younger dementia, and then he died not thinking anything more of it. It was eventually his assistant, just a minor detail, who also had a lot of pressure to publish. He just republished Dr. Alzheimer's work and kind of named it Alzheimer's disease to make it kind of unique so he could keep his tenure, and it just stuck. And over a century later, gene studies were done on the original brain tissue of this first patient, and she was found to have a genetic mutation for early onset Alzheimer's disease. So Alzheimer's disease refers to the type of dementia with these specific brain deposits, okay, and that's just the history behind that.
You mentioned early onset. What's the age range of typical early onset?
Sure, so we'll go through that more soon, but typically early onset is under age 60, 60 to 65, and it's very rare. It's 5% or less of general Alzheimer's cases, and it's got gene mutations specifically related to it. So another term you might hear, so that you can kind of put all this in perspective, is again somewhat dry sounding, but it's called mild cognitive impairment, or MCI, all right? MCI is thought to be sort of an intermediate state between normal thinking and dementia, because it is a continuum. You don't just get dementia one day, it is a continuum, and mild cognitive impairment is thought to be sort of the intermediate step. That's based on both symptoms of people who do eventually progress to dementia, and by studying brain tissue of people who died either with these symptoms, they showed brain deposits that were similar to Alzheimer's but not as much. So think of it as if osteopenia is like pre-osteoporosis, if you've heard of those terms, that mild cognitive impairment is sometimes considered potentially pre-dementia, but not always. There's about a 10% rate of progression of mild cognitive impairment to dementia each year. The difference between it and dementia is essentially you can still have that one abnormal aspect of thinking, whether it's memory or social, that is different from your baseline of where you normally were, but that it doesn't really impair with your life, that you're functioning just fine when your job, your relationships, your daily activities, your bills, it's not interfering with life in that way. Another term that you'll often hear is called pseudo-dementia. Pseudo means false or mimicking in dementia. And what that is essentially is that sometimes when a person has severely uncontrolled depression, that major depression can cause memory problems. It can cause word-finding difficulties, forgetfulness, feeling absent-minded and forgetting what you were talking about. It can really mimic depression, mimic dementia when in fact it's untreated depression, and that's what pseudo-dementia is. Unlike dementia, there's a few differences. Pseudo-dementia is usually more fast in its onset or noticeably starts more quickly, whereas dementia is a process that takes years and years. The mood is consistently depressed, whereas with dementia, you can also, of course, have depression, but it may go up and down. And really the last 2 points on there refer to an interesting observation, which is that people with pseudo-dementia are generally concerned about their memory problem, right? And in general, that is a good sign when you are concerned about your memory problem. It's not always, but more commonly, people with dementia or early dementia don't think there's a problem. They get upset whenever anyone talks to them about it or whenever anyone suggests it. So if you're concerned and coming to the doctor about memory, that itself is not a bad start, okay? All right, so that's the basic overview. Now you know some of the standard definitions. What are the causes of dementia? to give you just an overview, this is a quote from Brain on Fire by an author named Susanna Callahan. She had a very rare early onset reversible form of dementia where she had all the symptoms of it and then got better. And so she can kind of, her book is interesting about that. But essentially, the healthy brain is a symphony of 100 billion neurons, the actions of each individual brain cell harmonizing into a whole that enables thoughts, movements, memories, or even just a sneeze. So the brain is vastly complicated, more so than we can ever just point to a single cause. But for what it's worth, breaking down the anatomy that helps control all of those functions, and this is putting it a little simply, but it's helpful. You may have heard of the brain stem at the base of the brain. That's something all creatures have, and it controls the base things like breathing, consciousness, alertness. And then there's the cerebellum, which is also in the back of the head. That controls balance. If you've had too much to drink ever, that's the part of the brain that is affected. The thalamus is sort of a central processing region. Hippocampus is more in the temporal, which means the sides of the head, and is more associated with memory. Hypothalamus controls many, many hormones. And the cerebral cortex, which humans are unique for having such a large amount of, the frontal cortex of the brain, is what controls a lot of movement, thinking, personality, judgment, we say executive functioning, okay? So it is not this simple. There is massive overlap between all these systems and what they control, but this is a basic breakdown.
I have a question which
Please.
may be a little from left field. Does the pituitary gland play any part in dementia?
It is part of a processing area as well, but it's not one of the generally implicated areas of the brain. It's not one that's usually focused on in imaging studies, research studies, medications. What makes you ask that?
I have a wife that had to have something or other removed from on whatever it was.
I know.
Yeah, so she had to have a very sensitive operation.
Okay.
And, you know, she's on lifetime medication now to keep that aspect of her physiological things together. So, you know, her mother definitely went through what you described as Lewy body symptoms, at least, probably 10 years before she was taken from us with cancer.
Okay.
So, yeah.
Well, I'm sorry to hear that,
you know,
certainly.
You know, when these things stack up, you kind of start wondering
Right.
what's going to happen.
And
to me.
so the pituitary gland controls many hormones as well, and it's common to get both usually benign tumors there that sometimes, benign tumors that can secrete hormones and cause problems. Typically not implicated in dementia, but there are exceptions to everything, certainly.
Thank you.
Uh-huh.
Good answer.
So neurons, I won't bore you to death about the science here, but neurons are the building blocks of the brain. We all have billions of cells that make up our whole body, and neurons are the cells that control the brain. Basically, they have, I don't have a pointer, but this big, branchy area on the left side receives input from other neurons in the form of something called neurotransmitters, which is a chemical. You may have heard of things like serotonin, acetylcholine, norepinephrine. Those are all neurotransmitters. Each neuron receives messages from the left side, travels the message along something called an axon, which is that tube in the middle, and then transmits the chemicals and messages to the next neuron. There are billions and billions of these. For a little bit of perspective, the first neurotransmitter wasn't even discovered until the early 1900s. So we are really in the infancy of our understanding of the brain. And that was acetylcholine. The man won the Nobel Prize for it, and that is implicated largely in Alzheimer's as well. So this is a slide of neurons stained and looked at under a microscope. It's kind of beautiful, I think, as a picture. So what exactly is the problem then with Alzheimer's? So they're called plaques and tangles. These are the two abnormal deposits that occur in Alzheimer's disease. It has many different causes that play into this, both genetic and ones that just happen spontaneously, but mostly it derives from a protein called tau, which is something that stabilizes microtubules, which help support the neurons themselves. And due to different defects in this, two things build up: beta amyloid plaques and neurofibrillary tangles. The difference between them is just kind of the structure of them, fibers versus twisted cells, and whether they accumulate inside or outside the neuron. And they essentially cause brain damage over time. They primarily affect the hippocampus, which we were saying is a major hub of memory in the brain. So if you think of brain damage accumulating slowly over years and years in the area of your brain that primarily controls memory, you start to understand Alzheimer's dementia. All right, so this is a slide of brain tissue with neurons, but also these black and little brown blobs are the deposits. So it's not much to look at, but that's what Dr. Alzheimer saw under the microscope of his first patient. The dark, I know you can't see very well, but the darker blobs are plaques and tangles, and they just look slightly different, okay? And there's no way to officially diagnose this, obviously, until after death, right? So the only official way to diagnose Alzheimer's, which is these plaques, is an autopsy, which obviously we don't do any other time. A little bit about the genetics of Alzheimer's, because it's a very genetic disease that we're only slowly, recently starting to understand more. Is that there's two major types of Alzheimer's. So we were talking a little bit about early onset and late onset. Early onset Alzheimer's disease, again, is rare. It's 5% or less of cases. It's usually before age 60. And it's due to a very clear mutation, typically in one of 3 genes, which control a protein that can eventually turn into amyloid. And so if there's a defect in a gene that controls one of these proteins, then it leads to a premature buildup of the material that can cause those plaques or tangles, the brain damage. So the genes are called presenilin 1,2 and amyloid precursor protein. And I wrote on there that it's autosomal dominant. Have you heard that term before? Yes. Okay, so in genetics, there's 2 types of inheritance patterns. Autosomal means it's not on the sex-linked chromosomes, meaning it's not based on gender, versus X-linked means it is inherited by gender. And then dominant or recessive, meaning is it more likely to be inherited every generation or not. And so these gene mutations are inherited in a dominant way, so they can be really devastating in families that have a history of it. Late onset is just not so simple. It accounts for 95% of cases of Alzheimer's, usually after age 65, has genetic component as well, but other things we just don't totally understand. Acetylcholine, one of the neurotransmitters we discussed, plays a role. There's a lot of speculation and evidence that different lifestyle aspects can contribute to it as well. And so it's not something we totally understand, but it's not so simple as finding one gene as far as we know. So that is, oops, did I not update the diagnosis here? Oh yes, excuse me. So diagnosis. Like I said, this is frustrating. There's no blood test for dementia, never mind Alzheimer's. It doesn't show up on an x-ray, it doesn't show up on a CT scan, you can't pick it up on a questionnaire. It is a hard thing to nail down in a fast way, and that's okay. So the first place it usually starts is just a simple doctor's visit. So if you're ever concerned for yourself or a family member, you can just come in and talk, and we can get a basic overview of symptoms. Generally, I think it's good to reserve at least a couple visits for this discussion. Most doctors wouldn't label someone with something like dementia based on a 15-minute or a 30-minute visit. So the general discussion goes over symptoms, which can range wildly. So don't panic when you see things like forgetfulness, because we all get that too. It just, we're looking at is looking at if it's a change in your baseline symptoms, getting worse over time, interfering with life. So forgetfulness, difficulty handling financial affairs that a person used to be really good at, problems with judgment, whether it's interacting with strangers or driving or work or talking, again, with financial affairs. If there's other things that might be clouding the picture, like depression, and then absolutely we look at medications, which we're going to talk about in a second.
Like the definition of those teenagers.
Yeah, of all of those symptoms, I know. But that wasn't a change from their baseline. They were baseline awful.
Right.
So then there's something called the mini mental status exam, which I understand sounds insulting, that you could try to condense something as complex as dementia into a questionnaire, but it's a start. And then a physical exam. A little bit of breakdown of these things. One of the biggest reasons for coming into the doctor is to rule out other causes of these symptoms, because some things can mimic memory problems that aren't dementia. So like we said, depression is a very common cause of memory problems that is not dementia, that you wouldn't want a diagnosis wrongly applied. That's called pseudo-dementia. Medication side effects. So obviously medications are very helpful for many people for different reasons. They have their role, but they're also one of the first things we always look at whenever someone's having a problem. Some of the common culprits that, especially in older adults, can cause lightheadedness, memory difficulty, acting confused, are antihistamines, so things like Benadryl, allergy medicines can do it. But more infamous are the controlled substances, which are commonly used for things like sleep, for example. So Ambien keeps getting in trouble with drug companies for not making fully aware the problems that can follow the next day with problems with judgment. And in fact, in particular in women, it was found to linger longer in the blood, so that the maximum dose has been lowered dramatically in women. But there's many people out there still on the higher dosages. Also anti-anxiety medicines, and the brand names are up here, but they're things like alprazolam or other ones can sometimes, because of their long half-life in older adults, cause problems with memory. And we would hate to diagnose someone with dementia when maybe they're just on too many sedating medicines, right? Infection, interestingly, can cause memory problems. Something like a urinary tract infection that earlier in life might have showed up as pain and burning and a fever, later in life can have no symptoms other than the person acting very confused. Usually that happens faster, but that's one example. Another one is syphilis. Syphilis was one of the top worldwide causes of dementia for a long time, until penicillin was invented. So usually when we do blood tests, we check for syphilis as well. It's nothing personal, it just happens sometimes. And then obviously any signs of other neurologic conditions, such as a stroke or a tumor. Okay. Physical exam, the main point is just to, again, find any other missed causes of the memory impairment. So as part of the neurologic exam, we're checking for other neurologic causes: tremor, problems walking, any signs of past strokes, Parkinson's, tumors, anything else that could be causing this. The mini mental status exam is one of the more commonly used testing tools, at least especially in primary care offices, because it's something that can be done in a relatively focused way that is not bad at picking up moderate to severe dementia. It is a series of questions that go through things like recall, spelling a word backwards, following kind of multi-step commands, recreating a drawing, that detect approximately 87% of moderate to severe dementia when you back it up with tests like more involved neuropsychologic testing. It is not sensitive for milder problems, right? No test is great at that. And then there's also something called a mini-cog test, which, again, we don't diagnose things like dementia based on tests this simple, but what's often found to be very revealing in someone is just asking them to draw a picture of a clock, with a certain time on it. So if you say 10 after 2, that's actually a really complex task that takes a lot of executive functioning to put together numbers, spatial ability, motor function, and reasoning for things like 10 after 2. So that and recall often are, if you just do those tests, can really pick up someone you might otherwise not have expected was having such a hard time, because people are very good at kind of not showing symptoms otherwise. This is an example of some clock drawing tests in people with anywhere from normal, ignore the scores, that was some other score done for the study that these were in, but normal clock, and then both through mild, moderate, and severe dementia. You can see how the spatial reasoning just breaks down completely, that is a massive part of Alzheimer's dementia. Another picture is an artist called William Udermolen, and he would paint self-portraits throughout his life, and he started painting portraits when he was first diagnosed and kept going, and you'll notice that the spatial skills just really disintegrate in a really hard way. Okay, so what studies are done if you go to the doctor to talk about dementia? The point of this is to essentially rule out conditions other than dementia which could be missed. Those account for a very small amount of cases. So we check labs for vitamin deficiencies, thyroid disease. Thyroid disease does not cause dementia, but again, if your thyroid is extremely underactive, it can cause problems like depression, decreased memory, sluggishness that can look like dementia. So the point is to rule out other conditions that could be confused with it. There's not a routine role for genetic testing, because many people say, well, there were those genes that you just said are implicated in early onset Alzheimer's. Why can't we just check those and know? And the problem is that we're just not there with the technology yet. That when we do gene testing, there's a lot of false positives, meaning it might show you're positive for the gene, but you never have a problem, which is obviously upsetting and would change your life in a lot of ways. And also false negatives. If it's negative, it doesn't necessarily mean everything's okay. You always could do it, but it's also typically not covered by insurance, likely thousands of dollars, and again, doesn't give us any great information consistently. The other question is often to do things like neuropsychologic testing. That's basically more extended testing by a PhD doctor who is trained in both neurology and psychology to try to tease out more evidence of thinking problems, to try to differentiate between dementia or that precursor mild cognitive impairment. There again is no standardized set of definitions for these things. So testing is not always 100% accurate or consistent between different testers. So often, and then sometimes isn't covered by insurance as well and can be quite expensive. So sometimes it's helpful in differentiating early or mild cognitive impairment. And sometimes we do it once a year to kind of try to assess progression, but it doesn't have a clearly defined role. The other question is whether to get brain imaging, which is a CT or an MRI. These we didn't even have until the 1980s, if you can imagine how new that essentially is. The American Academy of Neurology recommends at least a brain CT, the idea of which is mainly, again, to exclude other causes of the memory problem, whether it's stroke or tumor, but it usually is negative. Okay. Sometimes an MRI can show a little bit of atrophy, which is shrinking in the temporal parts of the brain, which is the side where the hippocampus and memory are, but not always, and it doesn't change management. So all of these tests are often frustratingly normal. Knowing that, how do we treat dementia? So I wish it were different, but there is just no cure. It is a very new disease to humankind. Again, we didn't know about the first neurotransmitter till less than 100 years ago. The average life expectancy after diagnosis, and this is not always the case, but is anywhere from 3 to 8 years, okay? And that depends on people and how early and late they get diagnosed. Medications, the prescriptions we commonly use, and we'll talk about in a second, may delay the progression of the disease, depending on the study you read, from 6 to 18 months. Okay? That being said, there's no clear evidence showing that the medications delay the bigger things, like being having to need to go into a nursing home, for example, or dying. Okay, so these are kind of the hard facts about medications for dementia, that they at best delay the onset or the progression of therapy, but there's no clear evidence showing longer lifespan or longer time to be institutionalized. Okay? And I know that's hard to hear, but it's also important because it comes up when making decisions about how long to keep taking these pills and how many side effects you may want to tolerate. The medicines that are involved, they do play roles. So the first one is called cholinesterase inhibitors. It's kind of a double negative in that ACE at the end of a word means the breakdown of choline, which is acetylcholine. So it's a breakdown of it's a protein that breaks down that neurotransmitter, and the medicine is an inhibitor of that. So if you inhibit the protein that breaks things down, you get more of a neurotransmitter. So essentially you're getting more acetylcholine. Okay, that's the neurotransmitter that's involved. And it's just not so simple that you were deficient in acetylcholine, if that makes sense. So if you can, an example would be if you have a headache and you take Tylenol, it's not that you were deficient in Tylenol, it is just a more complicated mechanism. But this is one aspect of Alzheimer's. These are medicines called donepezil, rivastigmine. Aricept is one of the common ones that you hear about. That's the brand name for donepezil. They're approved for all stages of dementia. They are not typically used for mild cognitive impairment, which is pre-dementia. There's no evidence showing that that delays progression. But if someone is just really adamant, they can consider trying it for 2 months and see if there is any clear benefit. It's not without side effects. Okay, about 20% of people have some substantial gastrointestinal side effects, including nausea, vomiting, and diarrhea, which you can imagine can be really detrimental and to quality of life, which is one of our biggest focuses, really, with dementia. It also can lead to weight loss if you're not eating and you're, having diarrhea. So these are things we think about. Often they're temporary or at least improve a little bit, but it can happen. And then also there's rarely the effect that they can cause a slower heart rate. So in people who have slow heart rates to begin with or cardiac concerns in that region, we are cautious about starting medicines like this, if at all. The other big class is called NMDA receptor antagonist. So that's another type of receptor in the brain. It deals with a different type of neurotransmitter or chemical called glutamate. And these are medicines like memantine, which is also called Namenda, and they're approved for moderate to severe dementia. So they are thought to, interestingly, be kind of protective of the brain, that by working by that transmitter, it mitigates the damage done to the brain over time. So.
Excuse me, is that the latest one that they have been using that just came out?
It's not the latest one. The latest one is a little bit. This has been out for a while. The newer one, it's not in mass use yet. There's not enough clear evidence. Yeah. So these are the big ones. This one is thought to be neuroprotective, so that even in people who may stop the donepezil, they may continue this one if it's thought to have any benefit. But what about those plaques and tangles we talked about? What was the point of that? Why aren't we directing any therapy toward that? So interestingly, depressingly, but when studies have been done where the amyloid plaques have been removed from the mice of brains, which you can imagine some of the limitations of that study, but that there's no benefit seen at all. Okay, so it's not so simple as just undoing the damage. So if you can so the current thinking is that we're focusing too late in the disease, that the damage has already been done, and that by the time a person is showing symptoms, that they already have damage in about half the neurons or cells in the hippocampus, which is the part that controls memory. So an analogy for that, for example, is cholesterol and heart attacks. If you have a heart attack, right, you have cholesterol in your vessels of your heart. If you were to remove roto-rooter out all the cholesterol in your blood vessels, you would have still already had the damage to your heart. The muscle wall would be weakened and you would have the symptoms of that. So the brain is the same way. The thought is that instead of removing the cholesterol after the damage has been done, that by preventing the cholesterol from ever accumulating in the first place, from preventing it from causing damage, you can prevent the symptoms. And so that's what we're slowly realizing about dementia. How long to continue these medicines? This is a hard question that there is a lot of emotion wrapped up in. So for the donepezil, this is the medicine that essentially increases acetylcholine at the transmitter. We usually recommend stopping after about 2 months if there's no clear benefit. And that, again, there's no blood test for this. It is a hard thing to assess, but it's based on benefit seen either by the family or at the office when we're talking or testing. And then the other question, the other reasonable time to stop is when dementia has just progressed to an advanced area, an advanced stage. There's generally little benefit with it, and it's okay to stop. It is not giving up, it's not failure, it is just admitting the limitations of the medications. You could always continue it, and that is fine too. Memantine, which is the medicine that's thought to be more neuroprotective, usually is continued later, but when there's thought to be just very limited benefit and limited further room for delaying progression, it's okay to stop it. Another time is just when a person has trouble swallowing. It's okay to not force these things. Some people are faced with the difficult conversation of whether or not to get a feeding tube for them or their loved one. Generally, we don't recommend feeding tubes for dementia. They may help someone eat better, but what they really are known to clearly result in is more visits to the emergency room for infections, for being pulled out in a moment of agitation, and for not lengthening a person's life in any meaningful way. So it's clear detriment, no clear benefit. Okay, so it's not I understand the thinking that comes with it, but it is just not shown to be very helpful. 1 second. All right. Some of the other, we were talking mostly about memory and thinking problems, but some of the other symptoms that can come with dementia are psychiatric problems. So agitation, sexual inappropriateness, yelling, being fearful. Some of these things are far more upsetting to patients and their family than any memory problem ever could be. And so some of the non-medication treatments for this are aromatherapy. So that can be things like lemon balm or putting lavender oil sachets on either side of the pillow for an hour at bedtime. That can help sleep. Regular exercise is not something we're just saying to do to be nice. It makes a big difference on decreasing agitation and decreasing wandering. Sometimes people wander and get lost. Music therapy, pet therapy are all found to be helpful in calming down things like agitation. Avoiding naps, avoiding alcohol and caffeine later in the evening. Melatonin is kind of an herbal version of the brain's natural sleep chemical and can be helpful. Massage of someone's arm while they're eating can help them do better. And then sometimes there's a role for antidepressants. Antipsychotics come up not uncommonly for things like agitation, for example. And those are medicines like Seroquel, and that we typically hear about being used in people with schizophrenia. They do have a black box warning on them, meaning it's a big government-issued warning in the elderly regarding increased mortality or death. And so they're generally not recommended for agitation, but sometimes we're forced to make hard decisions based on what is the benefit and is that worth the risk. Yes?
In regards to sleep hygiene, what about the naps? If a person doesn't have a regular sleeping cycle, has very hard time going to bed, sleeping, I heard the opposite. Giving them, little capsules of nap time helps because of the brain itself needs some rest.
So you're right. It's not so clear as just no naps. And sleeping cycles do get disordered with dementia, just like everything else. So sometimes it can be helpful if people are waking up repeatedly at night. It doesn't work for everyone, or if their bedtime is just so delayed that they, are up later past everyone. No naps can be helpful to help them be asleep sooner. But sometimes it's the opposite. It's helpful to keep them awake from falling asleep early to get them on a regular schedule. So you're right. You're not doing anything terribly wrong by avoiding naps. It just depends on the person. Okay.
What is the significance of sundowning, and is it a concern?
So sundowning is a term that basically refers to when someone gets a little disoriented, whether it's due to the darkness or lack of orienting things on the wall like clocks or calendars, and they can be more agitated or more demented at night. The significance of it is it's just the nature of the illness. That can happen to people with no dementia at all. The hospital is notorious for it. When it's bright all the time, there's strangers coming in, that one day blurs into the other people can get confused. So it's sort of independent of dementia and a higher risk with older age.
I understand too when people use the computer or the iPads,
Mm-hmm.
that's too much light before they go to bed.
Good. So that's a common thing for anyone, that watching your computer, phone, or TV anytime near bedtime suppresses your brain's natural melatonin release, which is the chemical that helps induce sleep. So anyone who has any sleep problems shouldn't do any of that in bed, even though initially you can feel like it makes you feel tired, but it's counterproductive.
Good old-fashioned book hour.
Yeah, but even the book shouldn't be in bed, okay, because it's training your brain that it's okay to read in bed and not sleep. It's confusing. All right, so the risk factors for Alzheimer's. Risk factors don't mean causes, okay, but they are things that are associated and may have some causal role. The first three we can't do much about: our family history, our age. We said the rate goes up with age, and then mild cognitive impairment, which is that sort of milder thinking disorder, is a risk factor. But some of the other things that are strongly associated with dementia, we do have some control over. So I know it's hard, a little small on here, but vascular disease, high cholesterol, diabetes. Basically every risk factor for heart disease is a risk factor for dementia. Okay? Obesity is associated with higher rates of dementia, and then lower amounts of social, mental, and physical activity are associated with higher rates of dementia. The reasons for that are not totally clear. The thought is maybe that people who do more regular mental activity, it can be related to education, it may not be, are just functioning at a little bit higher level, so that when they do get the damage, that they don't show the symptoms so soon. And then alcohol abuse. How do we prevent Alzheimer's? There is no answer to this, unfortunately. But some of the things that are thought, and there is some evidence in delaying Alzheimer's or less association with Alzheimer's, are just like we said, good amounts of mental activity, so exercise, puzzles, art, games, less TV, less movies, less just receiving, there's some evidence potentially, forgive me, I didn't edit the slide totally, skip to the part of supplements. There's a lot of supplements that you'll hear about in Alzheimer's prevention. There's no good winner. Essentially, vitamin E, there's been some evidence of benefit, some conflicting, some concern for risk, especially with increased heart conditions. So increased risk of death in people with certain heart conditions like heart failure or coronary artery disease. So we don't know. Some neurologists will prescribe 2,000 units of vitamin E twice a day. Some will encourage you to get more from your diet. There's no clear evidence on this. There is no clear benefit seen for a lot of these other common things you hear about, which is ginkgo biloba, estrogen, B12, B6, vitamin D, folate, and omega-3 fatty acids. And I know that's depressing to hear all of that. It usually doesn't hurt, but there's no great evidence showing their benefit.
What I'm frustrated by is that it's been known that in India, they only have a 1% incident of Alzheimer's and dementia in their populace. And they find that it's due to the use of turmeric in their diet, and also different, a lot of them use curries and peppers and all kinds of different spices. They drink a special tea that has all these.
I know. So there's a lot of lot of discussion about what could be the cause, but correlation again doesn't mean the cause. And I'll warn you, in many places they say they have a lower rate of it, but they're not using the same standards for detecting it. People don't have the same access to medical care. For example, I did a 2-month rotation in Bali where I taught the doctors there a few years ago at a hospital, and they would always proudly announce that there's no diabetes, no emphysema, no mental health problems, but their suicide rate is quite substantial. Everyone smokes. Yeah, so sometimes, and I know it's not that easy, but you just can't always trust hearing a statistic like only 1%. That might just mean there's others not known.
Like Dr. Small at the University of California, he has an associate that has been doing a lot of this research, and he has done tests with people. And he's finding that the turmeric that has the black pepper, the other ingredients that are important for absorbing that does affect the brain.
Right. So there are some studies that show benefit, but there are just as many that show no benefit. So I'm just taking this from a much broader perspective, that I would love nothing more than to tell you all that turmeric made a significant difference, but it's just not been found to be the case reliably. It could change, but this is currently the case. The future of Alzheimer's disease, you'll hear a lot of talk about biomarkers. These are thought to be ways that we can detect Alzheimer's earlier, similar to how we check for cholesterol now and find out that you're someone at high risk, can be treated and prevented. Unfortunately, there's still no treatment. So even if there was a way to detect it particularly early, there's no medicine, there's no atorvastatin medicine to help prevent the problem. So biomarkers are things like PET scans, which is a fancy type of brain imaging that can pick up inflammation in different areas. Lumbar punctures, that's a picture on the left of what's called a champagne tap, when they are able to get someone's fluid around the spinal cord without any contamination. And genetic testing. So these are all ways in which we're looking to eventually be able to screen people earlier, much in the way that we do now with things like cholesterol and blood sugar testing. It is unfortunately not imminent, and there is still no treatment to prevent these things. A few brief mentions about safety concerns that are hard conversations to have. So one is driving. We commonly have family members come in and tell us that they're concerned about their loved ones driving. So you know where your doctor's coming from. California is one of just 5 states in the country where it's mandated for the doctor to report any sort of impairment to the DMV. And that results, not the DMV, the health department, and that results in suspension of the license. What does impairment mean? There's no great definition of that. Yeah, so obvious cases are lapses in consciousness, like seizures. If you pass out while driving, you can't drive until it is sorted out. And this is not personal, this is just a matter of safety for yourself and everyone around you. It results in suspension of the license. This can be overturned if the person goes to the DMV and passes a written and driving test. I've done many of these and had many people upset at me, and I always say that it can be overturned, and of the people that I see who go to get it, adamantly fixed, they inevitably don't pass the test. So It can be undone. Don't hate your doctor. It's mandated. If, on the other hand, you are the family member who's concerned and you don't want to be the bad guy, you can tell your doctor the concern and we can get our perspective. And we don't take it lightly, but it is absolutely a big concern. Isn't it
for your safety and the safety of others? I'm recommending that you have to take the test.
Right. So it's just, and part of, an example, and this wasn't necessarily a dementia case, but was the picture there is of that Santa Monica Farmers Market accident in 2003 where 10 people were killed from a confusion about the gas and the brake of the car. So it is rare, but it happens, and it doesn't need to happen to any of your loved ones. So this is something you should think about. And kind of the rule of thumb is if you don't feel safe driving with someone, then you should tell someone about it. Diet and exercise. So like I said, an exercise regimen is very helpful for decreasing problems like agitation and also for wandering. What's that? Low salt, yes, very good too. Alcohol use, we tell people a couple of things to usually limit to about 1 drink in a sitting, and this sounds silly, but people can sometimes lose track of how much they drink, and it can really add up over days and weeks and years and become a whole different problem. Usually avoid after dinner. Sometimes we feel that alcohol initially makes us feel sleepier, but what it really does is decrease the depth of your sleep cycles. You wake up more frequently. It's generally not good for sleep. That's for anybody. Also, decreased sense of smell that often comes with dementia may lower someone's appetite and they're just not interested in eating as much. So you can use high-calorie supplements. Those are things like Ensure. You can use spicy foods and spices to kind of increase the flavor, which might be too much for you, but it might taste better to the person who's affected. And then other considerations, I know I can't really emphasize it enough, an advance directive. So how many people here have an advance directive? All right, that's not bad. That's good. Some younger people here too, good. And there's kind of two big things. One, the point of an advance directive is to set up a durable power of attorney, a medical power of attorney, and that's the person who makes decisions for you when you can't. The time to set this up is when you're feeling fine, because if any aspect of impairment or memory sets in, you can't make these decisions, and then you're vulnerable to all the things that might be decided that you perhaps didn't want. So take someone you trust who is not so emotionally invested that maybe they can know what your wishes would be if there are any big concerns like if you stop breathing, if your heart stops beating, or if you're hospitalized. Another aspect to this is what's called the PULSed form. This is called Physician's Order for Life-Sustaining Treatment. While an advance directive is where you lay out what you would want to happen if you were incapacitated in a long-term way, the PULSed is a form that gives instructions for what you would want done if you were to essentially die. Okay, so I know this is a serious conversation that I cannot do justice to, but it outlines if you would like to be resuscitated in terms of compressions and a breathing tube and electric shock, all the way up to if you would like things like a breathing machine and a feeding tube. So this is obviously a personal conversation that is not as simple as it sounds of being resuscitated or not, and you should just talk to your doctor, get their perspective, and make it clear what you'd like done with your family as well. But everyone should really have that form on file at the doctor's office and at home. Okay? Do you continue all the other medicines? Often by the time someone is in later stages of dementia, they're on medicine for cholesterol, 2 medicines for diabetes, 2 medicines for blood pressure, medicine for their gout, their neuropathy, their sleep. We see people on 30 medicines. In addition to just potentially causing many interactions and symptoms on their own, it can increase your risk of falls, which is just really devastating. And it's a poor quality of life in somebody who maybe is in the later stages of dementia, having to choke down multiple pills all day. So it is a hard conversation for families. Sometimes they feel like they're giving up, or like it means they don't care if they consider cutting back on medicine for cholesterol when the person is no longer even able to speak, for example. But these things are okay. It just depends person by person. Just like you wouldn't start all medicines at the same time, you wouldn't stop many at the same time. So just take it into consideration and maybe talk to someone you trust about it. Being aware of signs of abuse. So people with dementia often aren't able to speak for themselves as much. And so if you have caretakers or if they live somewhere else, you should just look for any signs of a problem. Financial arrangements are a big deal. So now it's nicer. We can rely on things like automatic debit for bills. Joint bank accounts can help keep track of things, and just knowing that there are many people out there looking to take advantage of somebody with dementia and their finances. So having safeguards in place for that is important. Wandering is a term that is used to describe when someone may walk away and find themselves lost, and it can be absolutely devastating to a family to not be able to find your loved one. So if that's a concern, regular exercise helps reduce that. And there's also something called the Alzheimer's Association Safe Return Program, which is focused extensively around preventing this and fixing it if it does happen. Another thing that I always just include on any lecture on mental health at all is fighting the stigma of mental illness, whether it's depression, anxiety, or just dementia. This is a picture from the One Flew Over the Cuckoo's Nest movie, which was filmed at a real mental institution in Oregon or Washington, one of those cities. And they were originally going to use the actual patients there, but the director decided they weren't crazy enough, and so hired Danny DeVito and everyone. So that's kind of what we're fighting against in a lot of ways, and that's probably one of the biggest barriers to treatment in any form. So what you can do is just know that mental illness and dementia can affect anyone. You can provide emotional support. You don't make it a taboo topic that we can't talk about. Just educate yourself and others when the opportunity comes up. All right, so basic summary here. Just to recap, dementia is a term that describes any condition of chronically impaired thinking and functioning. There are many types, the most common of which is Alzheimer's, caused by abnormal deposits in the brain. And although there's no cure, there are important ways to help a loved one have a safe and comfortable life while living with it. And then future technology may enable early prevention and detection of this disease. Some resources that are helpful. I have no conflict of interest or disclosures with any of these people, but Beach Cities helps a lot of people with their care management program for seniors. It can help seniors and disabled adults, anyone who lives in the Beach Cities. And they also do a lot of in-home assessments and plans with a social worker. They can have someone come and help with things like bathing or running errands. And the phone number's up there. If you need it at the end, you just ask me. There's a very famous book called The 36-Hour Day, which is basically a resource for families or friends of someone with dementia. And it really educates you on a lot of the things that aren't so intuitive. And it's very helpful for what can be a very isolating role as the caretaker, right? There's also the Alzheimer's and Dementia program at UCLA. I understand that's a long ways away and that's not the first place you would go for treatment based on distance, but they do have on their website, which is dementia.uclahealth.org, they have free webinars for caregivers, which are helpful for a lot of people. And then if you did go up there, they have a care manager who's a nurse practitioner to help kind of coordinate the bigger picture. Okay, so if you need any of this, you let me know. And then the last part is just a little plug for the walking program I mentioned to a few of you at the beginning. Walking is good for just in terms of return on your investment for any condition is just fantastic. So there's a national program called Walk with a Doc, which I just started a local chapter of the program, and we meet once a month on the promenade, and you can walk fast or slow, short or long, alone or with us, ask medical questions or not. It's very low pressure, and everyone's welcome to come if they want. There's flyers back there, but that's it. Okay. So thank you very much. I know it's a kind of a tough topic, but I appreciate you coming out to listen. It really warms my heart to see everyone interested in their health. All right, questions? Okay. You can always find me afterward. I'll be here. Okay, and I work just next door if you need anything. Okay, I know. I wish it were lighter. Well, I know. I wish it were different. Thank you.
What are the early signs?
I'm sorry? Oh, the signs.
Just a quick question. All the signs that you've indicated have been found in here, there must be some very, very early signs that could be visually seen. Yeah?
Well, so early signs, if I say things, they're just going to be things we all have, which is word finding difficulty, getting lost, forgetting things, having trouble judging things. Usually it's something observed by the people around you and not you.
I've been like that since I was 20 years of age.
You've been what?
He's 94.
What
Yeah.
to do?
And that's okay, that's your baseline. We don't treat that.
Sounds like the old timers before you learned.
No, I think you're okay. That would be impressive.
They used to call it old timers.
They used to just think it was all vascular, that everyone just had hardening of the arteries, and then we realized that this deposit on the brain was the main cause.
I think it's kind of interesting. I know 4 people in my life that has had Alzheimer's. And my daughter-in-law, her mother had it, and her grandma. And when I went back to Sweden, her mother was completely nonverbal, had to have home health care and all that. And she put on a video of an old story and musical that was used when she was a child. The mother played piano and the girls sang with her in this musical. Well, being that I had worked with special education, I said, let's buy that and try it on your mother.
Yeah.
And we put the musical on, and when they started playing the song that the mother taught the 2 girls when they were like 5 and 6 years
She
old.
knew it.
She wiggled her toes,
Yeah.
and then before you know it, her hands were going like this, and I thought it was so interesting.
It is.
Because the music center of the brain is so
It's
much
separate.
separate.
So I used to volunteer or work at a veterans home in the dementia unit in New York, and it was, these are people who live there who are severely impaired, who often don't know their name, can hardly walk, nonverbal, and they would have a music therapy session, and someone would come in and play World War II songs. And I mean, these people would just know every word and line and be fluid and singing and on tone, and it was just unbelievable.
Right.
And something we don't understand. It makes me mildly concerned for the songs that I'll know if I have that problem. But yeah, so it's interesting. Yes.
I heard that there was a sort of genetic or cheek swab test and then figure out what are the right medications, what medications are most effective. What is that?
And you're saying in reference to dementia?
Yeah.
So there's a lot of things in development, but there's just none that are actually effective, if that makes sense. There's promising some things, but we don't usually implement things on a wide scale unless there's a lot of good evidence, because then if it's wrong, you have the potential to do harm potentially by starting too many medicines or leaning toward a medicine you wouldn't have otherwise done based on an insufficient test. So that could be the future, but not soon.
So for now, it's sort of a trial and error to see what.
For now, it's really 2 big classes of medicines: the Aricept type medicines, trying it for 2 months, seeing if there's a benefit, and then the protective medicines. And like I said, it is hard to measure a benefit, and so we're going on a lot of intuition. It's not easy.
Do you have any connections with the Alzheimer's Association?
No, but I refer people to them often for things like support groups and their safe return program. But they're a very, very good resource, and they have a lot of good information about the genetics and the causes of Alzheimer's on their website. Yes.
After you were mentioning mutations that were just discovered in 2008, it seems so recent.
Yes, but they're not all just in 2008, but some of the more newer ones that are implicated were found more recently. And you're right, and the history of mankind that we're just now learning genetics is impressive. So it was thought to be the big medical breakthrough on par with penicillin, and it could be, but it's just been unfolding a lot slower than we'd previously hoped. Another kind of interesting thing about the genetics component of Alzheimer's is that one of those 3 genes that we talked about are associated with early onset Alzheimer's is one that makes an amyloid precursor protein, and that's found on chromosome 21. And if you know what Down syndrome is, you know that those are people who are born with 3 copies of that chromosome. So therefore they have 3 copies of that gene, and they almost, without exception, develop the symptoms of Alzheimer's early in life, 40s or 50s.
My sister, or my daughter-in-law, her mother that had the Alzheimer's and grandmother, it's interesting to see how the doctors take care of her now that she's 48, because her mother started when she was 45, and they make sure that her thyroid is working properly. They check every metabolism thing, and her diet is carefully managed. She's on a very healthy diet.
Good.
She runs every day, and it's just very interesting because even the hormones, I know you didn't mention hormones, but she's on hormone therapy right now, and it's made a whole difference in her personality.
Well, I couldn't speak to that. It just depends on exactly what her dementia was. But hormones are something that have been prescribed, and again, her case may be different, but have been prescribed what's now considered a bit recklessly for a long time. And they're very popular in a lot of ways because it sounds nice, hormones, but they're not without their own risks too. So it just depends on each person's situation.
But it's just very interesting to see the heart doctor is very concerned about her cholesterol and
Well, good.
balances. And it's just really interesting because they know that the mother and the grandmother had Alzheimer's.
Yeah, so it's hard. Okay, well, thank you all for listening. If you have any questions, you let me know.